I was given a particularly hard challenge of trying to present to you how specific organ manifestations could actually influence treatment decisions. And I would challenge you as the audience to match the organ-specific response rate to the correct drug. The bar charts have been recolored, so you can't tell what they are from their original publications. And I'll give you all a second to, in your mind's eye, figure out which of the organ responses go with which drug. And so this was a little bit of a trick question because I've included rovadacitinib on the bottom right, which probably nobody thought about. But we have here axatilimab, belumosudil, Rux, and Rova. And you can see that really at first glance, it is very difficult to tell any of these curves apart. And in the highlight here, I have noted that in all of these drugs and trials, the upper and lower GI tract and the esophagus all appear to be the most commonly beneficial organs. So it doesn't matter what you use, your esophagus is going to get better. I think this three-stage paradigm of how we think about chronic GvHD has served us well. I think it is not a linear process, and I think that is where we sort of misthink how we approach therapeutics in chronic graft-versus-host disease, that when you see inflammation, there is also fibrosis ongoing, and vice versa, that when you see fibrosis, there is still also concurrent inflammation. And one can't necessarily choose a therapeutic agent based on the mechanism of action that we think we have in our mind and the desired effect. I'm going to give you some examples of that here. And so, we have no evidence that any of the individual drugs truly work better for one manifestation or the other. In all of our trials, we didn't limit the agents to the specific organ manifestations, although there was one exception with agave-201 where there was some benefit predominantly in skin tightening, although the overall response rate in the skin was remarkably low. And so I'm going to give you perhaps a made-up clinical trial. So this is a drug that is being tested in fibrotic chronic graft-versus-host disease. It's a phase 2 trial, and the trial was done in patients with advanced or established sclerosis, and the patients were given the drug for 6 months and then were tested for long-term follow-up. And here are the response rates. And so you see that in established sclerotic chronic GvHD, this drug worked in about half of individuals, with nearly 20% attaining disease stability and only a small rate of disease progression of about 20% or so. And so in your mind, you would be thinking that this is a drug that is probably defined or specifically used in sclerotic GvHD, but in fact, this is a JAK inhibitor, and the author of the study is in the audience today. And so as we think about JAK inhibitors, we all look at this diagram and we say JAK inhibitors are important for signal transduction of inflammatory signaling, and nowhere on this slide do you see anything related to sclerosis or fibrosis or myofibroblasts, and yet ruxolitinib clearly does work in sclerotic graft-versus-host disease. On the contrary, we have drugs such as the CSF1R inhibitors, which are theoretically specifically designed to impact the pathways that lead to laying down of collagen. And yet, when we look at the trials specifically looking at this agent, we see that sclerotic manifestations were in fact not the organs that had the best response rates at all. And again, I told you that we saw great response rates in the mouth. So inflammatory manifestations, right? The classic hot red lichenoid changes in the mouth got better with administration of axatilimab. So we do have to think that perhaps we are not using the drugs in the way we think we are using them. So how do we go about using clinical manifestations to meaningfully guide our treatment selection? Well, I think we do need some element of biomarkers that tell us a given drug is going to work in a given organ, and these might have to be organ-specific biomarkers. I think we fundamentally need a better understanding of the mechanism of action of our drugs, and I firmly believe we've somewhat reverse-engineered the way we understand the way our drugs work. And one great example of this are these two molecules, one of which is the enantiomer of the other with the simple addition of an amine group on the 6-member ring. And we call the drug on the left a JAK inhibitor, but the drug on the right is a combined JAK-ROCK inhibitor. And if there are any kinome inhibitor or kinome experts in the room who can explain to me how this is a fact, I'd love to hear that. In fact, when you look at the established drugs and you test the JAK inhibitors for their activity at ROCK and vice versa, test the ROCK inhibitors for their activity at the JAK, you see that there is a lot of crosstalk between these two kinases. And then finally, we do need organ-specific clinical trials. So if you're treating ocular GvHD, do we have head-to-head comparisons that one drug is better in the eye versus the other drug that might be better in the myofascia? So what are the goals, particularly in fibrotic chronic graft-versus-host disease? Well, I think there are 3 ways of dealing with fibrosis. So you can either prevent further inflammation to prevent further fibrosis. You can prevent fibrosis by direct immunosuppressive action, or finally, taking a non-immunologic approach to fibrosis. We look at the ROCK inhibitors, in particular belumosudil, and Bruce showed this slide in the earliest presentation this morning. To my knowledge, it's the only drug that, as of yet, has been demonstrated to directly reverse fibrosis. And this is an analysis that was done by the group at NIH looking at oral biopsies pre and post administration of belumosudil. And on the left-hand side of the slide, you see a decrease in staining for collagens type 1 and 3 in the mouth. And on the right-hand side, you see a decreased infiltration in the submucosa of T cells, and in particular IL-17 secreting T cells. So I think this is sort of prime evidence that we can do what we think we can do by the mechanism of action of the drug that we have. There are a ton of mechanisms by which we can approach fibrosis. As applied immunologists, most of us do not think about these pathways, but our colleagues who do renal medicine and hepatic medicine, where there are real problems with liver fibrosis and kidney fibrosis, they actually think about these pathways. And thinking about this in more detail gives us the opportunity to really attack an entirely different set of cells and cell subtypes that might be involved in the laying down of collagen and the pathophysiology of fibrosis. And then finally, there are tons of agents that are being tested currently by our colleagues in hepatology and nephrology. Some of them you might be aware of. Even axatilimab is on this list. I think the slide goes on for, there's a couple of them. But we as a field need to determine which of these pathways are most relevant in our patients and figure out a way in basket trials or umbrella trials to sequentially test these promising agents in our patients with fibrotic chronic GvHD. So the key takeaway here, the combination of inflammation and fibrosis is pivotal in chronic GvHD. We need to do better in terms of understanding how individual drugs work in the organs we are trying to target, and we really need to understand to some degree a little bit better the biological mechanisms of disease that lead to fibrosis.